understandable that it is 20% of all catheter ablations. It is increasing because of advancing age, hypertension, diabetes, and it becomes routine in day-to-day practice. And not properly dealing will lead to not only short-term, long-term poor outcome. The principle here is differential cutting and orthogonal displacement. Orthogonal displacement of friction, I mean during high-speed rotation, there is a longitudinal friction vector between the wire and burr, which makes a circumferential direction which facilitates the burr to advance in a challenging lesions. Differential cutting, I mean the inelastic tissue will get cut, whereas an elastic tissue will deflate away from the burr. If you compare the prepare calcium trial against older time Rotaxas trial, physicians have moved to radial, more complex lesions, but still safety was preserved, and 6 French guides for most of the time. Burr-to ratio was more than 0.5. Design class were used, Rota Pro were used, and intravascular imaging was used. And 2018, EAC endorses this device in selected cases for heavy calcification. And definite indication is 360-degree arc, napkin ring, and IVUS OCT microcatheter is not able to cross. Possible indication will be 180-degree arc. High-risk lesions will be lesions with the thrombus, dissection, and lesions with an angle and bypass graft. And last remaining with vessel with the compromised LV function, one should defer. And upfront rotational atherectomy is chosen by most of the senior operators. Non-senior operators start with balloon, but even in that group, I suggest provisional rotational atherectomy. Take lesser time, low threshold to convert to the rotational atherectomy rather than rescue, getting into complication. Putting a stent and ablating the stent is not the way to do it. And get the burr, do the job before the dissection prevents you that. And you need to consider in a left main trunk with LV dysfunction, hemodynamic support. In a CTO, if the calcified CTO is nothing is crossing. In a low EF also, again, LV assist device. In a bifurcation, final result will be good if you ablate well with the calcium. And calcific nodule, it was banked by our president. When there is a bias, it works. In ACS, data is nice, encouraging data is coming up. So I will take you through some 10 or 11 steps. Step 1 is a good BP in a patient, hold beta blockers. In a chip kind of a scenario, don't hesitate to take the help of assist device. A temporary pacemaker, when you think it's going to save you the day. And I will consider assist device particularly when there is a single remaining vessel, angulated lesions, long lesions, unprotected left main, and multi-vessels diffuse disease. And you know that even during complication, you may not be able to refer the patient to CABG. You cannot suddenly now find a patient for operable. It's inoperable to begin with, and during complication also it is inoperable. So you need to begin with the assist device. Senior operators may defer temporary pacemaker because of the pacemaker-induced perf. They think a short run may not push them into arrhythmic disturbance, or they can get away with a cough reflex. So then coming back to selecting the burr size, it's been already set, ratio, then I would like, by default, it's 1.5 burr, because 1.25 can end up in a trap. If it is a larger lesions, LMC alike, then 1.75 burr. The modern trend is single burr. So single burr with a low speed, it is equivalent to poor man's upsizing the burr. But sometimes you may have to do a second burr for effective lesion modification. When it is tortuous, CTO, severely calcified, then you have to start with 1.25 burr. If your default strategy is 1.5 in a vessel size of 2.5, in a vessel size of 3.5, it will be 1.75 burr. Having taken the 1.5 burr, if you think it is not working, then you have to downsize. In a case of 1.25 burr, whether it's a diamond fatigue or it has not really ablated, then you may have to upsize. Regarding various sizes of the burr, as the burr size advances, the area of diamond coating against the non-diamond coating becomes more. Look at the burr size of 1.5. The diamond coated area is almost more than the non-diamond area. So that's the reason why in a 1.25 burr with a lesser diamond area with a high speed, you don't ablate, you just cross and trap. Whereas in a 1.5 burr where the diamond area is more with a sensible speed, you ablate and you are doing a safe, effective ablation. So these are by default, I said 1.5. Sometimes you may have to downgrade to 1.25. Sometimes with 1.25, you may have to add a extra support wire to facilitate the burr, or sometimes you have to go back to the 1.5 burr again with a support wire. So this is the reason behind this. The support wire against floppy wire gives a better bias for the burr to advance, whereas 1.25 burr, one cannot omit 1.25 burr in our practice because the penetration force is good, whereas 1.5, the diamond area is good. So the guide should be coaxial. We can prefer a side hole, and you can, finally, if you think you are going to upsize the burr, your guide should accommodate your final size. And 6 French will accommodate 1.25 and 1.5, 7 for 1.75, and for 2 burr it is 8. Coaxiality, this is what I mean. Sometimes you see in LAO, but it may not be coaxial in RAO. This is a non-coaxiality in LAO. This is a non-coaxiality in RAO in an animation. Why it is difficult in an RCA osteal lesions? Because in LAO it will look like coaxial, but in RAO, in a cranial view, it doesn't look coaxial. That's why in RCA osteal lesions, rotational arthrotomy is demanding, because coaxially engaging as well as maintaining coaxiality is demanding. Regarding the floppy wire with extra support, the tapering is long in floppy, short in extra support, whereas the tip spring coil is larger in extra support, whereas shorter in floppy. Why I have to discuss this floppy versus extra support? Because the floppy wire with a tapered long and lesser diameter can ablate the calcium at the greater curvature, which is other way for extra support for ablating the calcium in lesser curvature. This is just an animation where 2 guides, multiple wires, which is talking about wire bias, favorable as well as unfavorable, to play with your burr. And regarding guide wire precautions, keep it as distal as possible, keep it in a larger vessel, make sure there is no, make sure you have put a wire clip torquer, and make sure there is no loop up front of the ostium after the guide, otherwise the rota will cut. And when you park it as distal as possible, then you get a better support for the burr to go in. And don't park your wire in a small branch, you may perforate during spinning. And this is about your favorable bias. When you sense your wire is cutting through the, crossing through the, in contact with the, not in contact with the calcific plaque, I mean, it is in contact with the non-calcific plaque, then you end up in dissection. Moved, whether it is working, then wire you should make sure the brake defeat is working, and then you advance the burr with take it proximal 1 to 2 centimeter proximal to the lesion. Either you can by single operator by pulling the wire and pushing the burr, or by activating the dyno glide. This is by once you reach the proximal portion, then you start activating the burr speed, and it should be short runs. In between the runs, there should be a good pause and pecking motion. Make sure the deceleration is not more than 5,000 final polishing run, and make sure ablations are not visual, auditory, tactile stimuli, all that you should respond. And we know how to remove the burr, and then it becomes, once the job is done, then becomes routine PCI. Let me quickly take you through some of my real world cases. 69-year-old.
Thank you, Shiva.